Well, good afternoon, and thank you for attending this virtual discussion about what I feel is an absolute game changer in respiratory care, because we know it is. Over the past years, we know we've reduced our intubation by over 60%, and that's CPAP. CPAP still is a very underutilized procedure. But it's getting stronger and stronger every day. Obviously, we know that this presentation is recorded, so it'll be difficult to address any questions you might have, but my contact information is all on the booklet. My name is Kent Anselmi. I'm the National Sales Manager of Pulmodyne. And a little bit about myself. I started 42 years ago, October 1st, on the street, 1979, as an EMT. And in 1982, I became a paramedic, and I still have those credentials today in the state of Kansas. You know, back in those days, we didn't have CPAP. We had a demand valve that progressed probably to a patient sitting up, and two people were trying to bag that patient while rotating tourniquets and a lot of Lasix and everything else. And then we went to nasal intubations, which was a difficult procedure in itself, and usually traumatized the patients a lot. And then in the late 90s, or the mid to late 90s, we got CPAP. And that was in the twilight of my career. So I didn't really get to use a lot of CPAP when I was a medic. But I want everybody to understand it's still a very underutilized procedure. So before we discuss our products at Pulmodyne, I want to just give you kind of a general overview of what's going on. And as we enter the cold and flu season, we call it the respiratory season. And obviously, with the pandemic we're in with COVID, it's very important to understand just the general points about CPAP. And I know there are people in South Dakota, departments in South Dakota, that are using the O2Max and GoPAP right now, and I appreciate that. But I know there's other people that don't, and that's fine also. But first and foremost, I want you to all to understand that I'm not a physician. And regardless of what I say, you need to follow your medical protocols and in your medical direction, first and foremost. Secondly, I'm not saying when I compare the O2Max and the GoPAP with any products that you are using, that what you're using is bad. I just want you to understand that there's a difference between our products and every other product, quite frankly, low pressure product on the market. And thirdly, and this is a very, very important point, and I stress this wherever I go across this country talking about CPAP, is CPAP needs to be started at the point of contact, meaning bedside, meaning in the house, in the apartment, wherever they are. Do not delay pressure and flow to these patients. It needs to be started at point of contact. And I've heard all the excuses, and I get it, but I don't get it, I guess. It's no different than if I ask everybody that's viewing this presentation, if you had a patient in the bedroom or wherever the point of contact was, and they were in ventricular fibrillation, would you shock them? And I'd almost guarantee every one of us would say, absolutely, we would. Well, time under pressure is the same as electricity in a shockable rhythm. So it's very, very important to start at a bedside. So what does CPAP stand for? And I'm sure most everybody knows, but it stands for continuous positive airway pressure. I like to put another C in there, and that's continuous and consistent positive airway pressure. And we'll talk more about that in a little bit, but remember, continuous and constant airway pressure. Little history about CPAP. CPAP was developed in 1950 by Dr. Colin Sullivan, who was really investigating sleep apnea. And that's how it all developed. And in 2007 or so, Dr. Busniak developed the first disposable CPAP, and it's still alive today. It's still available today. Now, there's 4 or 5 other low-pressure CPAPs available, but Dr. Busniak and the Busniak O2 system was developed in 2007. I don't want to spend a lot of time talking about COVID, even though it's extremely important and it's going to be with us for quite a long more time, I believe. But what we've learned initially for the COVID, that everybody was put on vents. You know, Pulmodyne is an international company, and we have distributors throughout the world. And whether it was in Brazil or Paris or Italy, you know, a lot of people were going on vents. And we saw that too in the United States. I mean, we even had Ford and GM building vents because we thought we were going to run out of them. But what we've learned through this whole process now, going on 8 months, 9 months, is that probably the vents are not the first line of defense. Quite honestly, in the acute care setting, it's high-flow nasal cannula. Well, there's really no high-flow nasal cannulas in the pre-hospital market right now, unless you're a transport service, critical care transport service. But we do have CPAP. So from high nasal flow cannulas to CPAP, and then possibly to a vent. CPAP, and in particular the O2Max, has really been well accepted all over the world and is used as a first-line treatment overseas every day. One of the things that we've learned by using CPAP is we need to have high flow, high pressure, and high flow, high pressure, and high oxygen. So, and one of our products can do that. So that's how we're using it in COVID. And like our medical director says, not every patient is a COVID patient, but we should treat every patient as a COVID patient now with PPE and like we're all doing right now. So let's talk about a normal, healthy person before we really start talking about CPAP. Probably, as you all know, we breathe 21% oxygen. That's what's in the atmosphere, 21%. We breathe against resistance. Every time we take a breath or exhale, we're breathing against resistance. And our intrinsic PEEP is about 5 centimeters of water pressure. And what that does is that maintains the recruitment and the patency of the alveoli, so we can have, you know, oxygen gas transport into the cells. Secondly, there's a thing called inspiratory flow demands. And as we sit here and we breathe and we take a breath in, we inhale about 20 to 25 liters of volume containing oxygen, nitrogen, carbon dioxide, other gases that inflate our lungs, okay? So 5 centimeters of intrinsic PEEP and about 20 to 25 liters of volume to maintain our lung compliance, if you will. When a patient is in CHF, let's just say, number one, their intrinsic PEEP can drop anywhere between 2 and 2.5. Okay, so you're already behind the 8 ball. The alveoli are shrinking up, are losing their patency, and you do not have that good surface tension to create transpulmonary circulation. So their inspiratory flow demands can go as high as 40 to 50 liters per minute, meaning you have to have a product that can supply at least that. COP is a whole different story. COP, their inspiratory flow demands can jump up to 70 or 80 liters per minute because their lungs are very stiff, they're atelectic, and you really, really need to provide a lot of flow to overcome those inspiratory flow demands. If you don't do that, you're going to lose their PEEP and you're really not going to do much. So I guess one of the questions I'm going to ask right off the bat is, if you're not using the O2Max or the GoPAP, ask yourself, what is the flow, what is the pressure, and what is the FiO2 I'm delivering with the system I'm using? Again, I'm not slamming it. I'm just going to point out some differences between what we're going to show you and what you're currently using. Is the flow enough to overcome inspiratory flow demands? Do you know what the flow is? So think about that as we go through the presentation. If we talk about the O2Max and the GoPAP, and think about what you're currently using. The other thing too, every system on the market on the low pressure side is flow-based PEEP, okay? And flow-based PEEP is exactly what it means. The PEEP is controlled by flow. To increase the PEEP, I turn the flow up. To decrease the PEEP, I turn the flow down. That's not really a natural PEEP because, as I said earlier, you're not breathing against resistance, you're breathing against flow. And it's like kind of putting your head out the window going 60 miles an hour, then down to 40 miles an hour, then up to 80 miles an hour. Every time you change that flow, you affect the work of breathing. And we're dealing with patients that already have issues with work of breathing. So it's not, I'm not going to say it's more of a relief valve, if you will, than true PEEP. The other thing that's very important is that we've learned, and I'm sure that your services all are very interested in filters. And filters on a low pressure system, especially when they're a flow base, they're not designed for any filter, because if you put a filter on that lower flow system, you're going to choke down the flow, okay? And you're going to create issues as far as PEEP, as far as back pressure, all kinds of issues. And more importantly, you're not going to get the flow to the patient that they require. Even that's true on our system, and we'll talk about that in a little bit. But we certainly are getting a lot higher flow than some of these systems out there. So I know, and going back to what I said earlier before we get into the product, is that second C of consistent. I mean, consistent flow is very, very important because it does not affect the work of breathing. It actually helps the work of breathing. So that's why I like to say consistent in the CPAP acronym. So let's talk about CPAP and our products. One of the first things that we don't make, we don't sell, but we talk about it wherever we go, and I talk about it everywhere I go. And this is a product that I wish I had in 1979, quite honestly, along with CPAP. And I'm going to hold these things up, and that's end-tidal CO2. Okay, this is a side stream, meaning it goes closest to the source. Do never use an intubated or mainstream line on a mask. You'll get too much wash and you won't get a good reading. When you're closer to the source, you'll have a little bit of reading or erroneous reading, but it will not, it'll be very, very consistent. And the reason why is you want to put this on first, run a baseline, and then put the mask on and the CPAP on, and then continue with end-tidal. So it's extremely important in any type of respiratory patient to have this on. It's actually important, I think, to have it anytime you're giving narcotics or anything. But again, follow your medical protocol, okay? And if you want to include this in either one of the packages that we have, there is a way to do that, and we can certainly share that with you later. So let's talk about the O2Max. This is what the O2Max looks like. Sorry, I have it upside down. Okay? The O2Max is a high pressure system. And what do I mean by that? It must go in to the on the EMS regulator, the high pressure port. Or it can go into a pigtail that's attached to the high pressure port. And I'll bet some of the people out there are thinking, oh my gosh, we're going to blow through oxygen, because every time we put our vents on a high flow system, we use a lot of oxygen. In fact, one of the initial CPAP devices in the pre-hospital market was the Emergent. And the Emergent was a yellow box that ran off oxygen, and people would get 4 to 8 minutes on a full D tank. Well, this does not blow through a lot of oxygen, okay? And I'm going to explain to you what happens. But it has to be put into the high pressure system. And that doesn't mean taking off the Christmas tree, screwing it into that, and turning the regulator on, okay? It has to be into the high pressure system. I've got everything exposed here, and I'm going to show you what it is. Everything in the kit. Remember what I said. You could even get it with a quick connect on it that would go right into the pigtail like this, and you would have CPAP without turning anything on. When I plug that in or screw that to the high pressure side, I pull 15 liters from the tank, and I entrain 125 liters from the ambient air, which gives me a flow of 140 liters. 140 liters to the PEEP valve at a fixed FiO2 of 30%, which is 9 more than we're getting from the atmospheric atmosphere. There are no moving parts in this. For anybody that wants to know, this works off Brunelli's principle, which means it's kind of like a jet engine. We've got a bigger hole up here and a smaller hole down here, and that's how we develop that flow. This is a 99.998 bacterial and viral filter. Very important with COVID, very important with other bacteria and viruses that are in the air that we forget about. It's going to stop it, most of it, from going down into the airway, okay? So this has an inspiratory filter on it. This one does not have an expiratory filter on it, but I will show you how we can do that. Again, 15 liters from the tank, 125 liters from the ambient air, which gives us our flow of 140 liters at a fixed FiO2 of 30%. This will stretch to 6 feet or 72 inches. You do not need to have this completely open, or it can be completely closed and it'll be fine. As we get to the PEEP valve area, we have an anti-asphyxia valve right here, which is very important. For whatever reason, if you lose your pressure or lose your flow, and you have the mask on the patient, this will flop down like it is right now, and the patient can breathe ambient air without suffocating. Very, very important. What sets this apart, other than what I've talked about, is what I'm going to talk about next, and that's the PEEP. Remember what we said. We breathe against resistance. Okay? That's how we're functioning as normal people right now. Well, the patients are also going to breathe against resistance with this. There is a spring in here, and when the patient breathes, they're breathing against that resistance. The other thing that's important is, regardless of what PEEP setting I have, and it will come out of the bag at 5, I can turn it to 7.5, and I can go all the way up to 10, okay, if I want to. Regardless of the PEEP setting I have, the flow is still 40 liters to that PEEP valve. It does not, you don't have to change the flow. It's plug it and forget it. The patient will receive, through friction loss and dead space, it will receive about 110 liters per minute. Okay? So that's as simple as it gets. Plug it in or screw it in and let it do its system. On a full D tank, non-nebulizing, you'll get about 26 minutes of runtime. Okay? If you want to put an exhalation filter on this system, remember what I said earlier, it chokes down the flow a little bit. We do make a filter that goes right like that, and then the mask will go right on here, okay? This is the same media that is in the exhalation filter, or this is the exhalation filter is the same as the inhalation filter right here. The mask comes in it. The mask itself is a hospital-grade mask, meaning it literally can go from bedside of the patient to the ICU, CCU. Okay? It's very simple. You put that in, the straps come applied at the top, let the mask float on the patient's face, clip the bottom ones in, and that's all there is to it. It's very, very simple. This mask does not take a lot of pressure to get a seal. In fact, this mask is designed that when it's pressurized, this blows against the patient, the outer lip blows against the patient's face, which provides that if you're using Entitle, which I hope you are, it will provide an adequate seal around that. Now, one of the other things we've learned about COVID is we know that every NIV mask leaks, okay? It's supposed to. It's supposed to release the CO2 over time. We don't want that CO2 or hypercarbonate buildup, okay, carbonate buildup. So we want it to blow, we want it to leak. So nothing is 100% with an NIV mask. But that's the system. Let's talk about nebulizing before we move on to a new product that very few people in the country have seen. In the bag comes a nebulizer and connecting tubing. We put it in a bag because we're not nebulize everybody, especially now with COVID. We're not nebulizing as much as we used to. So you can repurpose it if you don't. But it's a standard nebulizer, nebulizing canister, and connecting tubing. So all you have to do with the connecting tubing, since you're not using the Christmas tree, you can plug that into the Christmas tree. Plug this in here. Drop your medication in the top. Take this cap off and nebulize. Okay? That's a check valve. So you don't have to build out that T-tube anymore. You don't have to stop the flow once you decide to nebulize after you've started CPAP. It's just right here. That's off, that's on. And then you adjust your flow with your regulator, 6 to 8 liters, whatever your protocol is. So that's it. That's the O2Max disposable CPAP system. Again, 140 liters at a fixed FiO2 of 30%, okay? I wish I could answer any questions because I'm sure there are. One of the other things that's very, very important about this system is everything is made in the United States. Pulmodyne is in Indianapolis, and that's very important in this day and age. Every one of these systems is tested for flow before it leaves the plant, so we know they're all working before they leave the plant. So that's the O2Max. I'm going to show you something now that is soon to be on the market. And it's going to eliminate the need for an external filter. And this is called the O2Max Guard. Same top, same inhalation filter, same everything. But instead of putting this on like that, we have now put the filter on top of the circuit below the PEEP valve. So when the patient breathes, that gas, which escapes right here, is filtered, protecting the caregiver, protecting the patient. Not 100%, but doing the same as a filter, an external filter, if they use CPAP. And this will be on the market within the next 3 to 4 weeks. So 99.997 bacteria or viral filter, again 99.998 bacterial filter. Still now can use your external filter, or your filter, I'm sorry, or use your nebulizer, because you're not going to catch the droplets. Everything's the same. So look for that coming very, very soon. It's the only one that does that on the market right now in the disposable high pressure market. I look forward to all your questions on that, and I'll be glad to answer them. So let's talk now about the GoPAP. The GoPAP is our low pressure system, and we developed this about 4 years ago. And what we really wanted was something different than anything else on the market. Like I said earlier, all the low pressure systems on the market are flow based. Again, increase the PEEP, or increase the flow to increase the PEEP, and decrease the flow to decrease the PEEP. So we came out with what we call the GoPAP, okay? And that's what it looks like. It's a smaller footprint. In this one, you won't have to worry about the mask, because the mask is identical to what it is in the O2Max. On this system, it is going to use the low pressure system. So I am going to use the Christmas tree. But here's the beauty of it. Here's the difference. And here's what makes it so much better. Is I plug that in to the Christmas tree, and you can see on there, it says 10 liters per minute. You turn the regulator to 10 liters per minute and you forget it. You never, ever adjust it again. Again, it gets back to that constant flow and consistent flow, okay? It will come out of the bag at 10 centimeters of PEEP. Why do you say 10 centimeters of PEEP when we're using low flow and we're using 5 centimeters of PEEP on high flow? Well, lower flow doesn't give you the flow to the patient that you need, so you need higher pressure. So it'll come out of the bag at 10 centimeters of PEEP. If the patient needs to go down a little bit, all you have to do is turn that to 7.5 or 5.5, okay? Again, the patient is breathing against resistance. This is a spring in here. They're breathing against that resistance, which is very, very important and very, very natural. So it's as simple as putting, this on, just like that, setting that to 10 liters per minute, and putting it on the patient. On a full D tank, with this system, you'll get over 40 minutes of runtime. So a lot of runtime to keep them on that D cylinder, start CPAP at bedside. The other thing is, if you want to nebulize off this, this comes in the bag also. I'm nebulizing, okay? Now, when this system, you'll have to use a second regulator to nebulize, but we do make a product called the Quick Connect that goes right into the high pressure side that you can put on, and it'll flow off the same regulator. But that's the GoPAP. 140 liter, pardon me. 10 liters per minute will give you 90 liters to the patient at a fixed FiO2 of approximately 30%, okay? Still enough to overcome inspiratory flow demands. But it doesn't have a filter. Now, even with this system, I do not recommend putting a filter on a low pressure system. Why? Because even at 90 liters per, if I didn't have this filter on, this will choke that flow down in the 70s and probably, and sometimes even lower. So we don't want to use filters with low pressure systems. Again, consult with your medical control, and if that's what you want to put a filter on, that's fine, if it's under their jurisdiction. That's the GoPAP. Still made in the United States. Everything's good. Still checked. But for low flow versus high flow. One of the other advantages of Pulmodyne is you can get the mask individually. Okay. About 80% of your patients will fit into the medium mask, and it's all about where you size it. You want to size it at reading glass level, not up at eyeglass level. You want to keep it low. But we make a small, a medium, a large, and an extra large mask. And you can purchase those separately. Most people will buy the medium circuit and then have a large mask for the 10% the patients or whatever that you need that. For those people out there that are using vents, this mask is a fantastic mask for vent patients. For any of the vents that we have on the ambulances and or the hospitals. It works very, very well. I want to ask for questions, but I know that's not going to work. So, but that's CPAP. I mean, ask yourself, like I said, to kind of recap. We need a constant, continuous airway pressure. We need to overcome the inspiratory flow demands. You know, we need to start CPAP at bedside. So I know a lot of you are doing that, and it's just a good reminder. We're moving into, obviously, the cold and flu season right now, coupled with the COVID issue that's still very, very prevalent. So we just need to be aware of what our systems do. The Guard is going to set the bar as far as it's the only one that is a high pressure system that has not only an inspiratory filter but an expiratory filter on it. So ask yourself, I mean, really, if you're not using this product or the O2Max or the Guard, I'm sorry, the Guard, the O2Max, or the GoPAP, you know, what's your flow? What's your pressure? What's your FiO2? And am I overcoming the inspiratory flow demands? Not here to say what you're using is bad, but I just want to bring that into light a little bit. Important to use end tidal with any type of respiratory patient. It's probably important to use it with a lot more than respiratory patients, but for sure. Like I said earlier, it's a very underutilized product. CPAP is a BLS function in all 50 states. So it's approved in all 50 states for BLS and should be started immediately. So that's my presentation on CPAP. I welcome your questions. I will do my best to get back to you just as quick as I can. While I have you here and we have a few more minutes, I want to talk to you about a couple other products that I think are very good. And the first one, I'm going to kind of get away from airway and we'll come back into airway. But I want to talk to you about a product that we just actually acquired that is a cervical collar, okay? And it's a vacuum splint. And it's called the Sysquick. This product, when I first saw it, I will be very honest, I thought this is kind of a gimmick, but it's really not. It stabilizes the neck very well. It can be used in both adults and pediatric patients, and it's very, very simple to apply. It comes with the pump, and when you're done, you throw it away. So I'm going to apply it to myself, which is kind of goofy, but it simply goes around your neck like this and attaches over here. It's Velcro. And you simply pump this up like that. And there I go. I'm in it. There's a clamp here. You can clamp it off. You can take that off. And you're done. And you can reposition it. But think about the elderly people or people in nursing homes that have fallen, and maybe your protocol says a fall, we have to put them in a C-collar. This is not uncomfortable at all. This is not rigid. This is just, I mean, it immobilizes the cervical spine. And we know when we get to the hospital, most of the time the physicians are going to take them off. But it's just a great adjunct to cervical immobilization. For a pediatric patient, you can turn this around, you can crunch it down, you can make it, you can take care of them also. But again, it's up to your medical direction. But like I said, when I first saw it, I thought, oh, this is silly. But the more and more I use it, the more and more I put it on. It is a wonderful, and it's comfortable. It's very, very comfortable. So anyway, that's the Sysquick. So to take it off, I mean, it'll just come off, and there it is. So we have all the kind of literature on this if you want it also. So that's the Sysquick. The last thing I want to talk to you about, and I don't know what, and I apologize, what your protocols are for a surgical crike. But I want to at least share this with you because this has really started to take off in the United States. And it's called the ControlCry. A little bit about the ControlCry. It was developed by Dr. Rich Levitan and Dr. Bob Mabry. Dr. Bob Mabry is a lieutenant colonel in the military. He's in charge of all the battle theaters in Afghanistan and Iraq. And the military was having an issue with doing surgical crikes in the field. And in the military, that's what they do if you need an airway. They don't do a lot of them. They do about less than 1% of them, of the casualties. They do surgical crikes. But they had about a 66% first pass. And so he and Dr. Levitan got together and developed the ControlCry. There's two versions of the ControlCry. This is the trainer and then the sterile version, and I'll talk to you a little bit about that in a minute. But it's very, very simple to use. Let's face it, we don't do a lot of surgical crikes, okay? We don't train a lot on surgical crikes. I never did a surgical crike. I did a percutaneous one time, which was a disaster, but we don't do a lot of them. So if I never showed you, I'm sure that not a lot of people have seen this, but if I open this up, that's, I bet you everybody knows which pouch we're going to go to first, okay? And what makes this unique is this knife. So most every special operations medic in the military has access to this. This is the airway of choice for the TCCC. It's been used 10 to 15 times in the civilian population in the United States with 100% first pass, from cardiac arrest to car train, a lot of bad trauma, but it's been used in the United States. And usually cut to air is anywhere from 30 to 40 seconds, which is really phenomenal. So let me tell you real quick about the ControlCry. The military wanted some way to mark the cricothyroid membrane. So there's a marker right here. It's not a Sharpie or anything, but it will leave a mark in your hand or in your cricothyroid membrane. The blade itself is a bidirectional blade, okay? It's 10 centimeters wide, 8 centimeters long, okay? Like I said, it's bidirectional. So when I make a vertical cut, first, I don't have to take the scalpel out. You want to rest your hand on the patient's chest, kind of use this as an X-Acto knife and just cut, okay, down to the cricothyroid membrane. Every neck is different, okay? So you want to expose the anatomy. When I get to the cricothyroid membrane, I want to make a plunge cut down. My trach hook is right here. I pull up the distal part of the thyroid cartilage, and I have total control over the trachea. Okay. This is how the military went from a 66% to 100% first pass. This is how it's worked 15 times or 100% on the 10 to 15 patients we've done in the pre-hospital market in the United States. This is a 19 centimeter anteriorly curved bougie, if you will, with a caudate tip. Okay. 5.5 millimeter cuff millimeter tube. So when I go down into the trachea, I want to bounce it. I want to feel it. I want to feel the tracheal ring. Okay. If I feel those tracheal rings or feel that vibration, there's only one place I can be. Push it down, pull this out, inflate the cuff, which is in here, and I'm done. In package 3 is a securing device. This, regardless of the side of the neck, this goes like this, wraps around the patient's face or neck, and I'm secured. There is an extender here that I can put on. And that's all there is to it. It's very, very simple. It takes a very low frequency, high acuity procedure and makes it a little bit easier. But we certainly have all kinds of videos on this. We have everything, everything you need if you are interested in this. And we'll be more than happy, or I'll be more than happy to share it with you. Speaking of that, I don't know if you know this, but our website is www.pulmodyne.com. I know you have my contact information. We have our own EMS Airway, which is in gyms and other magazines every month. We have a full library of training videos and brochures that we can certainly send you. We're here to help you through this process. We have an unbelievable marketing department, and if you need something, certainly call me. If you have a question, I'm always available for a call. I'm like I tell everybody, I'm a phone call away if you need me. So that's my presentation. I would hope that that you all have questions. And I hope you're all healthy and safe, and I appreciate your time. I know this is different doing a virtual deal, and I keep looking down. Don't mean to look down. I'm trying to look at the camera, but I don't know. Those are just things you have to learn. But I appreciate all your time, and I hope you have a good virtual sales meeting. Thank you very much, and I look forward to your questions. Have a great day. Goodbye.